My name is Nora Downey. I'm a project manager for the Serious Illness Care program at Ariadne Labs. I'll be the host of the webinar today, and we're really glad that you're able to join us. This webinar, as you can see here, is going to be an overview of the Serious Illness Care program's COVID-19 response toolkit, which we just put out. Do the next slide. We usually do our webinars in WebEx, but this is kind of new for us. So bear with us while we get used to this Zoom environment. But this should be what your screen looks like. There's a bottom menu that I want to point out where you have functions in which you can chat, raise your hand, or use the Q&A. We will only be monitoring the Q&A today. So I want to direct you there if you have any questions. We'll have some clinicians who will be able to respond to those questions in real time, and we'll also have a time for question and answer at the end of the webinar. All right, and so here we have our presenters today. We have Jo Palladino. She is one of the clinical faculty in the Serious Illness Care program, specifically working on the community of practice. And she was one of the primary developers of the toolkit that we'll be presenting today. We also have Rochelle Bernacchi, who is on our community of practice team as well. She is going to be reporting on a team at Partners work, which are presenting how to implement this sort of a response toolkit at this time. And then we're also going to have contributions from Eric Fromme and Justin Sanders, who also worked with Jo to develop this toolkit for COVID response with an extensive team, but this is some of us who have worked on it. And again, I'm Nora Downey, and I will be hosting today.
Thank you so much, Nora. So welcome, everyone. Thank you so much for taking the time to join us. My name is Jo Palladino. I'm a palliative care physician with the Serious Illness Care program at Ariadne Labs. And we're really going to be talking about the resources that we're developing in response to COVID-19. And what we're hoping is that at the end of today's webinar, you'll be able to engage in conversations with patients or families using some of the COVID-19 communication tools that we're going to discuss. Recognize the opportunity to incorporate system-level approaches for high-quality communication during this pandemic, and also know where and how to access additional resources and updates. This is very much meant to be kind of a living, breathing toolkit that will be updated over time with feedback. And so just to name up front some of the context within which we're all experiencing right now, this is an extraordinary time with unprecedented challenges. And we've heard from our primary care colleagues, for example, that they have patients, older adults sometimes, calling them from the community, saying, I just want you to know that under no circumstances do I ever want to be on a breathing machine or even go to the hospital. And so there's a lot of conversation in the community happening right now with heightened emotions and collective fear and distress. We're also talking to colleagues and many of us as well working in the hospital, and hearing stories about patients who are doing well, laughing maybe on the phone with their family, and then they just get very sick and go to the ICU. And colleagues are having to have conversations with family on the phone because of the need for an interpreter. And this just highlights that communication, especially about values and preferences, is more important and also more challenging than ever, with all of the many virtual technologies, no visitation policies, et cetera. And this is all existing kind of within this realm of the moral distress that we feel from worries about resource allocation and crisis standards, as well as how quickly things are moving and evolving. And so we developed multiple types of COVID-19 adapted communication tools, as well as some supportive resources, really with the goals of ensuring that patients and families feel informed and prepared and well cared for, that clinicians feel prepared and supported to engage in conversations and decision-making with patients and families. and that implementers, leaders, health professionals have access to tools that are scalable, adaptable, as well as resources that they can implement and disseminate widely within their organization. And so I'm really going to just share an overview of the Serious Illness Care Program Response Toolkit and really do a deep dive on the conversation guides in particular. And so just so you know, if you Google Serious Illness Care Program COVID-19 response, the website in which this is publicly available, which is right here, will come up immediately. And at the end, we'll also share some additional locations to access these tools. And so as an overview, here's what's in the toolkit. We have tools for outpatient care, many of which are built around a conversation guide, but include additional supportive resources. Tools for inpatient care, as well as patient resources. And as you can see, most of the tools here are completed already, including video demonstrations that are ready or near ready, and others are in development, namely a conversation guide focused on when crisis standards have to be activated. And so what we're really going to focus on today are the conversation guides themselves, and just give you a preview of some of the other tools. So I'll start with the conversation guide for COVID-19 for outpatient care. Just to let you know a little bit about the design process. So we went through an extensive adaptation process with rapid iteration. We adapted the original version of our serious illness conversation guide, which is a patient-tested evidence-based tool. And we really articulated our guiding values and principles that led to development of that guide and tried to stick to them in this approach. We also got feedback from a diverse group of individuals on face validity, including a caregiver advocate, as well as health professionals of multiple professional backgrounds in primary care, family medicine, nephrology, palliative care, many of whom work in the ambulatory setting. And many clinicians were willing to use this, and so we got feedback from user experience, from having conversations with patients, as well as from simulations with a patient actor. And this process is what led to the tool that we're going to talk about today. And so what is the COVID high-risk conversation guide for outpatient care? Really, it equips clinicians to proactively outreach to high-risk patients in the community who may be at higher risk of complications and serious and critical illness from COVID because of their underlying health conditions. It emphasizes both prevention, protection from getting the virus in the first place, and preparation in case they do. And it focuses on what matters most, as well as conversations with patients' trusted decision makers, including identifying a decision maker. And these conversations will often occur by telehealth as part of a routine visit or as a separate visit. And so now, just to bring this to life, I'm going to show this conversation guide being demonstrated by Dr. Justin Sanders and a patient, Mr. Garcia. Just 2 minutes of this so you can see what the video demonstration looks like, and to bring this to life for you before I walk through the guide itself.
I would love if we could spend just a few more minutes together. This is a difficult and scary time with the coronavirus, as I think we're all feeling. I'm hoping we can talk about what's important to you so that we can provide you with the best care possible in this time. Is that okay?
Sure, yeah.
Okay. What do you understand about how the coronavirus could affect your health?
Well, I understand that in people my age and older, it can be pretty severe. So that's the thing that I hear the most.
Okay. And what are you currently doing to protect yourself from getting the virus?
Only going out when necessary.
Okay.
Going to the supermarket, the pharmacy if I need to pick something up. And we'll go out around the neighborhood here if there's a sunny day, but we'll keep our distance from people if we bump into anybody when we see them on the street.
Good. It sounds like you're taking the social distancing really seriously, which I'm really glad about. How about your granddaughter? She lives with you and I think is 19, is that right?
Yeah.
How is that going?
Yeah, well, she is still a teenager, so it's kind of rough for her, but I think she's at the point where she understands how serious this is. She's really getting it.
Good. I'm glad to hear that.
Yeah.
May I share with you my understanding of how the coronavirus could affect your health?
Sure.
Okay. most people who get the coronavirus get better on their own, okay? However, people who are older or have health problems like yours can get very sick and may not survive. The treatments that we use to try to help people live, like breathing machines, may not work. And if they do work, recovery from the illness is uncertain.
Are you saying this applies to me?
It sounds like it's kind of surprising to hear that it might.
Yeah, it is surprising. I mean, do you think I'm going to catch it?
Well, we really hope you do not get the virus, first and foremost. But it's important to prepare in case you do.
Yeah.
Okay, so you had a chance just to see a short preview of the conversation. The conversation itself is under 10 minutes. So now I'm going to talk through the guide briefly, and just to name it, for those of you familiar with our original guide, it has the same structure: set up, assess, share, explore, and then close and recommend. And so I'm not going to go through each area specifically. I'm really going to focus on the areas that feel the most different, as well as places where there were some tensions and some of the choices we made, just to try to make those transparent. And so as you could see, we felt it important in the setup to really name that this is a difficult and scary time with coronavirus, really just as an indicator of this shared experience. The rest of the setup largely looks quite similar to our other guide. As you heard Justin say in the video, the assess section, we added a specific open-ended question about protection measures, because we felt that as one of the biggest priorities is to ensure that patients are protecting themselves and to provide an opportunity to counsel patients, which might happen either in this moment in the conversation, or it might be bookmarked if there's additional counseling needed to happen at the end of the conversation. So in the share section, which is sharing information, this is where this will look very different. And so I just want to name a few tensions that came up from the reviewers as we were navigating this process. The first was to balance how much information to share, working on not sharing too much so that you overwhelm patients, and not sharing too little so that they don't have enough information to understand and to think about what would be important to them. The second was just the uncertainty of this virus. Many people recover, some don't, especially worries about those with underlying conditions. And then lastly, just thinking about how to titrate this information to the patient's anxiety. And so what we really did was, the choices we made is that we shared as an opening that many people who get the coronavirus recover and get better on their own. And however, we wanted to let people know that those who are older or who have other health problems like theirs may get very sick and may not survive, and that the treatments that they use may not work, and recovery would be uncertain. So this was a way of trying to strike a balance with how much information to share in this context, with, of course, a pause and responding to emotion. And this is all framed in the Hope Prepare model, that the goal is we hope you don't get this virus, and we want to just prepare in case we do by ensuring that we know what's important to you if you were to get very sick, so that can guide your care, which is the goal of the rest of the conversation. And so in the Explore section, we maintain the spirit of open-ended questions about what's important, worries, what abilities are really important to patients' lives that they can't imagine living without them. We also added, in the latter part of the Explore section, we really wanted to give people an opportunity to bring into this conversation some of their preferences. Now, people may be in very different places about whether they've thought about what kinds of treatments they may or may not want if they were to get very sick. And so we decided to go with soft language, just by asking, have you thought about medical treatments that you may or may not want, to give people a chance to express those preferences and also say, I haven't given much thought to this. And then maintaining a question about family involvement and family knowledge of the patient's wishes. And then lastly, there were numerous tensions around the recommendation, specifically how specific the content should be in the recommendation. We had some folks who really wanted, to think about including something like a pulsed form or a mulched form in the recommendations. Others who felt that that might convey a rush to life or death decisions when these are patients in the community, who may have underlying illnesses but may be doing quite well. And then the second is that there's a variety of possible next steps here. And it's really important, I think, to think about the fact that, not all recommendations will be the same. So how can we handle that? And so what the choices we made is that, by kind of naming that this is hard to talk about, reflecting back what we heard the patient say is what's important. We were thinking that for every patient, it feels really important to really have a sense of who their trusted decision maker would be, and to really encourage and recommend that they have conversations about what's important with their loved ones. And it's an opportunity to share resources to support that if you have them. And then lastly, in the close, and then we also added an open-ended recommendation in which we allowed clinicians to share the recommendation based on their clinical knowledge. With a close, this is an uncertain time, and we will do everything we can to help you through this as a way of just reaffirming commitment to care with the patient. And so just to note the choices we made, the trade-offs we considered, every guide has trade-offs. It's not to say that they're right, but we're really making them transparent so you could understand the why behind the language, and also think about how that might work in the context in which you practice and work. So now I'm just going to share a few case studies about how the guide is being used in real life. These are actual clinical encounters in which clinicians use this conversation with a patient or a family member in the community. So first is an older adult in the community with multiple medical illnesses. And this was a conversation between her family medicine physician, herself, and her daughter. She actually has coronavirus, is able to communicate during this discussion, is febrile, but is able to actually speak without any shortness of breath. And so during this conversation, it became clear that for the patient, the best case scenario was to stay home if possible, as much as possible, but she was open to receiving care in the hospital if that was needed to provide her more support to help her feel better. She did express having limits. She wanted to be DNR, DNI, and there was a fair amount of counseling about whether or not she wanted to go to the hospital should she actually get sicker and require more care. So what they decided in that moment was to focus on increasing home services and then documenting her code status in the medical record. This is a conversation between a palliative care, in this case, palliative care physician, and a patient with advanced lung cancer, as well as type 1 diabetes. He's Portuguese speaking, so this was done with an interpreter. He lives with his wife and his daughter. He does not have symptoms of the virus currently. And this is an example of what is very common, which is patients and their family members not feeling the same way about what's important and their wishes. And so in this case, the patient said, if I get very sick, just make me comfortable. I don't want to suffer. Whereas his wife said, do everything you can to save him. And so in this case, they discussed that at this stage, recommending hospitalization if needed felt appropriate. And it allowed them to really plant the seeds that if he got sicker, there are worries that given his advancing illness, that he might not, do well with these particular treatments, and so it ensured that that if that were to happen, it wouldn't be the first time they had this conversation. This is a patient between a primary care nurse care coordinator and the son of an 86-year-old woman who lives with advanced dementia. She's very frail, requires 24-hour care. Her son is her proxy, and she lives in assisted living, and she has been exposed to the virus. And so what was learned from this conversation was that, in this case, as you can tell, the patient had the patient's son, had prior discussions, and this patient had a MOLST with a DNR, DNI, but an okay to send to the hospital. And after this discussion, he made it clear that he doesn't want his mom to go to the hospital under any circumstances. And so they made a recommendation to refer her to hospice. And the caveat here is that not all hospices accept patients with COVID, and there are very specific regulations. And so this is something that they were working on. They updated the MOLST to include a do not hospitalize, and they confirmed with assisted living that they could provide care for her should she actually develop the virus and get sick. And lastly, this is a 42-year-old man who lives with his wife and 2 teenage sons. This is a young patient with advanced sarcoma on third-line chemotherapy. This is a palliative care telehealth visit. And in this case, the patient was really not ready to talk about this, said multiple times, let's not discuss this now, numerous questions about coronavirus in general, and very anxious and expressing that anything besides living is not okay. And so in this case, the clinician paused the conversation, responded to emotion, responded to questions, and then they were able to spend their time focusing on counseling around the prevention itself. And also they were able to actually talk about a surrogate decision maker to have that in the medical record. And so I bring these cases up both to just show the different diverse patient settings or contexts within which this tool has been used, but also to say that we develop supportive implementation resources based on the needs that we identified from this formative process that we went through. So we heard, for example, that these can be hard conversations, and having them over telemedicine can be awkward. And so we adapted a tool developed by our colleagues at Mass General to just provide some tips about how to have more sensitive conversations over telemedicine, coming from many from best practices, often in palliative care. And as you can also saw from the clinical encounters, there's a range of recommendations that could come from an outpatient conversation. And so we adapted an existing tool by providing some examples of recommendations in the domains of well-being, illness management, as well as patient social supports to support clinicians in making recommendations. It's really a supplemental tool. And then lastly, clinics and systems have very different resources within their system for things like mental and behavioral health, for palliative care, for hospice, home services, et cetera. And we wanted to have a single page where clinicians could input their resources that they have or don't have, so that it lived in one place and they could also potentially identify gaps. And so those are the implementation resources for the outpatient guide. Now I'm just going to talk through the inpatient guide. I'm not going to go through it to the same degree we just talked about here. I'll just really focus on a few key areas for the inpatient guide. And as you can tell, we use a very similar design process for this guide. And the only difference is to say that the people who were involved in giving us feedback as well as sharing user experience were hospitalists, palliative care clinicians, emergency department physicians, and so we had a diverse group of professionals from multiple backgrounds. And so the goals of the inpatient conversation guide are to equip clinicians to have conversations with patients with confirmed or suspected COVID in the hospital or with family members. And ideally as early in the admission as possible, because patients can get sick quickly. So this could happen in different parts of the hospital, the ED, the floor, for example. It emphasizes patients' values, priorities, and preferences so we can honor them. And it informs decision-making about life-sustaining treatment. So one of the things that is happening in the hospital is that in many cases, like my husband's a hospitalist, for example, they can't really have a presumed code status. It's really important that there's a confirmed conversation about code status with either the patient or their family. And so we felt it really important that this guide could lead to a decision about life-sustaining treatments at the end. And just to note what this isn't, it's not a guide for crisis standards. It also isn't a guide that could potentially be used if somebody is coming in emergently to the emergency department needing intubation. And so we retain the same structure as the other guide. I'm not going to go through each section again, but I will just highlight 2 particular parts of the guide, because I think it's the area that we actually spent the most time developing with feedback from others. One is the information that is shared with patients. One of the big tensions is that there's a lot of uncertainty. You could have a young patient doing well and then they get sick really quickly. In other cases, patients are actually sick. Patients have underlying health conditions and you have a different kind of worry about them. And so what we did in the share section is we created options. So we started by sharing, many people will recover from this infection and we're going to do everything we can to help you recover. And as you've probably heard, some people get so sick that they do not survive. And so this just kind of presents an overall kind of uncertainty of this illness. And then for patients who you might who you might think have normal risk, what we wanted to do was normalize the discussion. Everyone should have this conversation. So because there is some uncertainty about how this illness affects people, we're asking everyone to share what would be important if they became very sick and couldn't speak for themselves. If the patient was someone at high risk, we really wanted to share a tailored information to them. So because of your conditions, if you get really sick, I worry that the treatments that we can use to try to help people get better, like breathing machines or CPR, are not likely to work or get you back to the quality of life you had before, with a pause to share, to respond to emotion. And then after the explore question, which included questions about what's important, trade-offs, abilities, etc., one of the questions we face is, recommendations may be different, of course, and people may also not be certain about what their preferences are. And so I'll share a little bit about about the choice we made in the closed section. Really maintaining that reflection back. I heard you say this is really important to you. Given what you told me and what we know about your current health, I would recommend, and here again, we presented 2 different options, similar to what we did in the share section. The first is to use intensive care if necessary, including CPR or breathing machines. We also added, if something were to change to make us worry that these treatments are not likely to work, we will tell you or your loved one. Is that okay? And then second, provide only treatments that we think would be helpful. And this means that we would not do CPR or breathing machines, but we'll provide all other available treatments to help you recover and be comfortable. Is that okay? And sometimes if it's not certain, if you're not certain about the recommendation, actually sharing a recommendation and asking the patient if that's okay might help them feel like they could make a decision in that moment. And then lastly, just closing with, we can revisit this and we will do everything we can to help you and your family through this. And so just to share a few tips for the conversation, I think that these are tips that really came from our colleagues that are using this right now in this context. The first is for both guides, read the guide aloud before using it. The second is to stick to the language on the guide. I think that there's a lot of distress and cognitive load is very high right now. And so it's our natural inclination to use our own words, and sticking to the language, especially when first trying it, is really important. And so some people add after the setup, I'm going to use this guide. I just want to make sure, so I may be looking down. I just want to make sure we don't miss anything, as a way of breaking down that barrier with the patient, to let the patient know. When working with surrogates, consider using video whenever possible, just to build that connection, because it is quite hard on the phone. That may not be possible, but it's something to consider. When working with interpreters, being able to go through the guide with the interpreter in advance is really helpful, and to discuss any anticipated challenges. Of course, using silence and responding to emotions when they arise. And I also think this is just a really hard time, and reaching out to each other, connecting with colleagues, sharing conversations that may have been really difficult, debriefing to provide support can be really important in this moment. And then lastly, before I turn over to Rochelle, I'm just going to share that we have some patient resources as well that we've developed in collaboration with the Conversation Project at the Institute for Healthcare Improvement. Eric Frome has led the development of this tool. And so the first is now ready and available, being prepared in the time of COVID-19. And this really supports patients in doing 3 steps. One is identifying someone they trust to make decisions. The second is talking about what matters with their loved ones. And the third is thinking about what would be important and what they might want if they became very sick, by responding to a few open-ended questions. We're also developing an email outreach letter to patients, which is forthcoming. Now, lastly, to talk a little bit about a systems approach to thinking about communication at a broad level, especially about values and preferences and other things, I'm going to turn it over to Rochelle, who is going to share just a story from our home system. And Rochelle, I'll advance for you, so you just tell me when you're ready.
Okay, fantastic. Thanks so much, Joe. Before I start about sort of the systems approach, I just want to emphasize a few of the conversation guide tips that Joe talked about, because I spent the last week in the hospital in the ED setting having these conversations, and they are really hard. I think the use of interpreters is fantastic and also challenging. Last week at the beginning of the week, we did not have the ability to use an interpreter and a video at the same time, so that was difficult. I also think that I made a lot of, or our team was making a lot of recommendations, which were in the B category, which was thinking about not using CPR, not intubating. And we had a lot of patients and families, primarily family members, that were, you know, not assenting or not agreeing to those kinds of recommendations. And I think that's par for the course. Given that we're doing these conversations over the phone via interpreters with families who are in really high amounts of anxiety. So one of the things we found was really helpful was to be really open about giving patients and families time to think about things and just sort of keeping it an open conversation. And then that last point about never struggling alone, I think my nurse practitioner and a fellow and I had so many discussions about how we're doing these conversations and doing sort of a real-time quality improvement process after each conversation and thinking about how did that go? What could we have done differently? You know, how can we think about this for the next time is really super important. And so for anyone out there doing these conversations at the hospital, I feel for you, they're really hard. And I think often also we still have the opportunity to have incredibly meaningful conversations with families that are really so scared and distressed. And, you know, these are really hard times. So I think resilience is really important right now. So those are just some of my experiences from the hospital setting. But I'm going to talk actually about how Partners is thinking about outreach to patients and families. So we have I'm going to talk specifically about the Brigham response, although I know a little bit about what Mass General is doing as well as Dana-Farber. I talked a little bit about what I was experiencing for those hospitalized. There's real challenges in this virtual care. I have to say last week I had experience where we moved into a building where there were wooden doors and I could no longer see the patients, and I felt really strongly that I needed to see the patient. We didn't have the video capacities up yet. So our nurses, who have been phenomenal, kind of gowned me up and put me in. So that was fantastic. And then we have completely changed the structure of our palliative care program at Dana-Farber. So we have an ICU team that is now following about 30 of our ventilated patients. We have about 65 in the hospital right now. They embed and they round with ICU team daily. We also have an emergency department and hospital medicine team that's led by Josh Lakin and I, and we're proactively reaching out in some circumstances. And then lastly, our regular sort of palliative care service. We also, Mass General has implemented a peer support line because I think some of these conversations are incredibly difficult. And so Juliet Jacobson is leading that. Okay, next slide, Joe. Okay, so these slides are courtesy of Christine Ritchie, who is at Mass General as well as Partners Population Health. And this is the way Partners, which is an 11 hospital system, is thinking about risk stratification and outreach to high-risk patients. And I think it's important to know that many patients are really expecting to hear from us during this time and really want to talk to their PCPs, their oncologists, their palliative care clinicians during this time. So we've identified 3 groups. The first is the medium risk, those 70 plus, and not either of the other categories. The medium high risk, those 80 plus with frailty. We're trying to implement a way to identify frailty via the medical record. And then 70 plus with respiratory disease, cardiovascular disease, and diabetes. That medium high risk group is quite large. Although we'd like to do very robust outreach to that group, the size of it is a bit overwhelming. So right now, we're really focusing on those high risk and patients with serious illness. Next slide. So for medium risk group, I talked to Christine yesterday, and I think there's a letter that's still being finalized by the Patient and Family Relations group, and I think that will be going out soon. As I said, for the medium high risk group, we're still struggling a little bit, to be honest, with that group and how to best utilize our resources to get to that group. But the high risk group, all PCPs last week got lists of their high risk patients, and they are doing outreach to those patients and having a telehealth conversation. You know, the idea is to at least have a proxy and essentially do what Joe just so beautifully outlined, have a conversation just like that. But the other things that we are trying to think about are home supplies, functional support, anxieties, concerns, those kinds of things. You know, just making sure that people have enough food and having resources to have that conversation. So yesterday I actually presented some of the Ariadne guide to our PCPs, as well as some changes that have happened in Massachusetts regarding the MOLS form. We now can do verbal consent via the telephone for most. So trying to update all our PCPs about that. I think right now what we're trying to do is some of our PCPs have extremely long lists of patients to outreach to. And we're trying to figure out how to get additional resources to them. So essentially, we have some palliative care social workers, some PAs, some nurse practitioners, and other people on our palliative care team that are volunteering to help some of these PCPs in having conversations, as particularly for the ones that you know, may have very long lists or are sick themselves, have other circumstances. And it's been a lot of coordination from the standpoint of geriatrics and palliative care. The other thing, I think it's a time when I feel really grateful that we have a really robust integrated care management program at Partners that identifies high risk patients. And we have teams of clinicians at all the sites, and it's called ICMP, where we have high-risk case management nurses doing a lot of this outreach. And so we have the infrastructure to kind of implement something like this rather quickly, and longstanding relationships that allow us to do that. The other things that I think have been really helpful from a systems level is that we have a Partners Palliative Care Steering Committee that currently, for the last, I think, 3 or 4 weeks has been meeting weekly just to talk about issues. So things like, you know, say the MOLS form where the Department of Public Health got the verbal consent and code status. We changed some of our code status orders so that outpatient clinicians could actually enter a code status into the medical record that obviously would be confirmed if the patient was to reach the hospitalization. But Erica Wilson has been doing an enormous amount of work on that. And then getting resources about hospice available, who is able to take COVID positive patients, and Julia Gallagher has been leading that. So I think it's really a time where it's super important to be coordinating care and not reinventing the wheel at every site, you know, especially if you're in a huge system like ours. So it's been, I can't take credit individually for any of this. It's been just an enormous amount of coordination and kind of thinking through the problems on the fly and trying to come up with our best possible solutions, knowing they're imperfect, as I'll quote Erica. So I think that's all I have to say, Joe. Thank you so much. Do you want me to go through this slide, Joe?
Oh, I got it. Can you hear me now?
Yeah. Okay.
Great. Thank you so much, Rochelle. And I think that, you know, I just quickly to build on that, I think that there are many health systems that are taking, you know, very diverse approaches to thinking about this at a system level. And one of the things that we're hoping, and I'm going to talk about this right now, to learn is really what health systems, what clinics are doing to respond to this in different ways. And so just to share a little bit with you about what's next, we have a COVID-19 conversation guide for crisis standards that's in development now. and will be ready soon. As I mentioned, there's an email letter for outreach to patients that we will be developing and sharing publicly. Also, just so you know a little bit about the quality improvement methods, we are going to be developing a quick survey for feedback on the COVID-19 conversation guides, really to refine the tools based on a diverse range of experiences. We'll be working with implementing health system partners to really develop case studies about what different diverse systems working in very different contexts with variable resources are doing to respond to this. What are the challenges? What are some of the things that are enabling their work? And to collect stories as well. And I think that we're hoping that really informs the implementation tools that we develop, because we want them to be pragmatic and as useful as possible to support clinicians in practice and also implementers who are thinking about this at a large level. And so now I'm going to turn this over. We have been looking at questions that were being asked during this, as well as want to open this up for more conversation. So I'm going to turn this over to Justin. Is that right, Nora?
Yes, hi there.
Oh, great, there you are.
We've had some specific questions come in, a couple which I'm gonna direct in a minute to specific individuals, but I just wanted to highlight a few, some themes that have come across, and to make sure that everybody's aware, even those who are listening by phone or can't otherwise see the questions section. So the first thing is around adaptation. We're getting lots of questions about whether or not the tools are available for adaptation, or whether or not we already have adapted versions. I will say that currently we have an adapted version in French and Mandarin, Mandarin Chinese, which may seem kind of random, but those are versions that we have available now. We will have a Spanish adapted version, but we would be delighted in general to have your adaptations in any language. And so I've heard today from people from Bangladesh and Denmark, and as I said, we would be delighted to have your translation of these guides and your dissemination through your networks. And so for an adaptable Word version of the guide, please email seriousillnesscare@ariadnelabs.org, and we will be able to send you a Word document that will give you some of the format that may make it easier for you to do the translation. Although the important thing to note is that the materials are protected under Creative Commons license, and so that guidance can be had on the guide itself about how to do that. The other question has been about the inpatient guide, and the inpatient guide, as Joe alluded to, is something that's coming very shortly. I anticipate that will be on our website today or tomorrow, and so that will be available at the website that Joe referenced. Rochelle, there were a couple specific questions about the response at partners that I wonder if you could field. One being about how partners or other systems were defining high risk. I know that on our guide we have referenced the CDC guidelines on who is high risk, but I'm curious if you could comment both on that, and also another question about another question, Rochelle, about the trained outreach team of clinicians doing in-person home visits?
Okay, that one's probably easier, so I'll start with that. No, our outreach team is doing it via telephone. Of course, we still have Partners Home Care, which is obviously doing in-person home visits. And for people who are very ill, I mean, this has been actually a challenge in terms of coordinating between geriatric or PCPs and hospice and who we can get out to the home. So that's been really hard, but we have been able to get our home hospital team sometimes out there. But for the most part, most of the outreach is via phone. So for the high risk, that's a great question. We already had an algorithm that was based on it's the ICD-9 codes of who can kind of screen into this integrated high-risk care management program. However, we have plenty of patients that are high risk that don't fall into that. And so it's an algorithm that's being run at partners level, and it's imperfect, I would say, but I think we're letting our PCPs use it and sort of filter it themselves, but I think it is helpful to them in that they get a list of patients that, you know, have been defined as high risk, and we give them a fair amount of leeway in terms of who they think is most important to outreach to. The other thing that I just want to highlight, what Joe said, which is so incredibly important, is about the anxiety issue and titrating our recommendations to anxiety. I talked to the PCPs and some of the geriatricians about that, and I got like 3 or 4 emails yesterday and a phone call about how important that was. And so just reminding people about that. I think some patients are super anxious, and a conversation is not going to be fruitful, and just kind of, you know, taking the temperature of your patient and thinking about, you know, what the most gentle approach. And I think that was nicely illustrated in Joe's example with a young patient with sarcoma, where we just have a healthcare proxy. So, but I think that piece, if you're supporting a group of PCPs, I think that titration and that tension is really important to highlight with them, because they're feeling it.
Can I just add something real quick, Rochelle? I also just wanted to name that in addition to thinking about for that particular patient, in addition to the decision maker, this is also an opportunity to identify patients who are struggling with high levels of anxiety and distress, and to see if you can get them into treatment. And so, you know, so part of this also is thinking, you know, especially in the outpatient ambulatory setting, holistically about how we think about recommendations. As you mentioned, it's not just about some of the things that we think about in terms of proxy and documenting decisions. Sometimes it is, and other times it's about getting telehealth-based mental and behavioral health, if that's possible, as well as additional management at home for a number of other things. And so we're just learning that these things are coming up in these conversations. And the recommendation kind of aid that we have is just built around that model that you just very nicely outlined.
I think the other thing that, Joe, that came to mind is from the hospital standpoint, you know, using our approach about, you know, having a very wide net and not always having to have these, even though code status and intubation feel really important right now, they're not always the most important thing that we could be talking with our patients, especially that are patients and families that are hospitalized. I guess that was one lesson for me last week as well. Even though you can have and I hear your husband Savin, the hospitalist, you know, we need to know, and sort of being okay with this uncertainty. So I've had a lot of families say, you know, I hear you, Dr. Bernecki, that makes sense. I understand he's really sick, and I really want him to stay full support, full code right now. And if he gets sicker, I'm happy to have another conversation, and that's fine. Like, that's totally fine to have that happen. And then kind of walking our ICU and hospitalist colleagues through that and being okay with that. And so we have to sort of meet our patients and families halfway. It feels a little uncomfortable. I just want to name that there's a tension there that feels uncomfortable.
Thank you both. I just want to acknowledge that a few more questions have come through that we can sort of bring into the larger group. One is around whether or not we have tools adapted for skilled nursing facilities. You know, this is a clear need that we're hearing, and I think we all worry a lot about what the impact will be in nursing homes everywhere, especially from what we're hearing based on what's happened in New York. And so this is something we're thinking very carefully about right now in terms of specific resources for skilled nursing facilities. So I would just say stay tuned for that. There's a question that came through about how does spiritual care figure into recommendation?
Listen, before you go on, can I say one more thing about skilled nursing facilities? Yeah,
Please.
So I've had, there's a wonderful Jerry Powell podcast with the head of a skilled nursing facility in Virginia that was terrific, where they had an outbreak and was really helpful. I also had a conversation with Muriel Gillick, who is kind of a geriatric guru, this morning, and she's very worried about that and so thoughtful. And so Muriel would be happy to help us think through those kind of issues, because she's really worried that even if, you know, I'm seeing the numbers level off at the Brigham, I hope I'm not, don't have anyone hold me to it, but I have seen that. But, you know, Muriel's point was a lot of concern about the nursing home still. So.
Yeah. Sorry for the typing. Another question that came through was around how spiritual care figures into the recommendations. And, I think that as Joe alluded to in the beginning, in creating a conversation guide that is to be used in a world in which there are infinite numbers of distress and possibilities, I think we had to make specific choices. I think if you're a spiritual care provider, it would make sense to integrate that into the recommendations that you have. And so we've tried to really create space in these conversations for clinicians of all types to bring their expertise to the conversations, and really to create space so that they can share the things that they know and worry about, and help patients think through next courses of action, whether they're in the outpatient setting or in the inpatient setting. So thank you for that question. Rochelle, wondering if you could share off, we will share in the chat box about the Jerry Powell podcast, or in the Q&A section if people are interested. Rochelle, perhaps you could post that. So another question came in. We continue to hear from physicians the desire for an algorithm to guide their advanced care planning and serious illness conversations. Do you have any related resources to share? Again, this is something that is very fluid right now. I think that we have struggled to, with this problem ourselves of understanding, who's at high risk in this situation. We get more data, every week about patients that we might be more or less worried about. We don't have any specific resources related to that, but I would encourage people to look at the CDC to see what their guidance is around who is or is not high risk. What I would say is that, and we have discussed this within our group, is that the group of, our original tools were developed specifically for seriously ill patients, those with advanced illness, whether it's end-stage organ disease, advanced cancer. And we are now in this world where patients who we would not have considered the complications. So we're finding many of our partners that the urgency to have these conversations is even greater, and with a larger group of people. So would anybody add anything about that? Joe?
No.
Can you hear me?
Mm-hmm.
Okay. Some other questions are being answered live in the box. Eric, I'm wondering, there's a few questions coming through about MOLST and eMOLST. I don't know if it would be helpful to sort of discuss that within the context of this, some of what you've already answered and maybe some of the questions that are coming through.
Let me see. Well, I'll say just a little bit about it. I think the problem with MOLST and POLST is that it varies from state to state. And one of the attendees from New York was noting that New York has a very robust eMOLST process, and that's available to everybody throughout the state. In Massachusetts, we don't have that. We have a paper form, and we're trying to figure out sort of on the fly how to create the capacity to complete the forms remotely, because now all of a sudden a paper form doesn't seem like the best thing to be passing around. And if you're interested, I guess, in what you can do or what's going on in your own state, I would direct you to the pulse.org website. There is a tab for professionals, and you can click on your own state to connect with the people who are spearheading your state's program. Again, some states have a very robust program, and others are still in development.
We're hearing through the chat box that at NYU, the eMOLST has been used very well. It's been very helpful. So that's great to hear. There's a couple of questions that have come through in rapid succession. So give me 1 second to just, one is about, are you sending follow-up resources, print or email to patients after the serious illness conversation guide output? So it's further things to think about. Eric, do you want to answer that one?
Sure. So the work that we've done with the Conversation Project, let me see. was really, it's designed to hopefully be applicable to any patient, whether they have done advanced care planning before or not. And it's really trying to focus them on, given the current situation, what are some proactive things they can do to control what they can control, given that there's a lot of things that are uncertain and that they can't control. And the focus for the conversation guide that's patient and family facing is really on getting them to identify a surrogate decision maker, to have a conversation about the kind of care that they would or wouldn't want, and then to communicate that what they feel with their family and potentially with a primary care physician or health care professional. So those are the three steps, as I think Joe said, and it doesn't necessarily steer people directly into completing an advanced directive or something like that. It does contain some information about the COVID illness in our attempt to try to explain, like, what's really problematic about the infection, which is the acute respiratory distress syndrome, that if somebody who's seriously ill develops that, then the outcomes, as one of my patients said, are either bad or worse. And so trying to help patients understand that before they make any decisions about life-sustaining treatment is important.
Okay.
I think we just have,
Go ahead, Joe.
probably, we're just 3 minutes. Justin, is there one quick question you can answer?
There's a good one, yeah. So can all COVID resources be listed together on the Ariadne site, including the patient-facing guide? The answer is yes. So if you go to the website that is in the presentation, which we will be, which are all here, you will see lists not only to our communication resources, but also to those from others, including the Vital Talk COVID Ready Communication Skills Playbook, those resources on the Center to Advance Palliative Care site, the CDC, etc. And so we will continue to update our tools and resources over the next period of time. I think we're all hoping we're through this sooner rather than later. But and we also welcome your outreach to us through seriousillnesscare@ariadnelabs.org. And we would, if you see things that you think we can improve, please let us know.
Thank you. And lastly, Rochelle, was there something you wanted to say about?
Yeah, I just wanted to make it really clear from Stanley. I thought that was a great question about home-based care to COVID patients, transfer to hospital. Hospices are taking COVID patients at home. So, reach out to your hospice medical directors. Not all of them can, but many are. But inpatient hospices, that's a little more challenging. The other thing that I wanted to add, do you have any guides for rapid response teams? We don't have that, but Andy Lawton made a phenomenal video, which we can post, of an ED conversation. I think it's really, I actually used the exact framework and it worked really well on several occasions last week. So we can post that video as well.
Great.
Rochelle, before you go off, do you want to just share a little bit about joining the COP and becoming an ambassador?
Oh, absolutely, yes. So we'd love for anyone who's on this to join the community of practice. We've got about 2,000 people. We are learning so much from you, and it's been fantastic. So please join. And then we are working on a program to promote serious illness care ambassadors. So, people that have implemented the program at their home institutions. And so we'd love for you to apply. The applications were due tomorrow, but given how busy everyone is, we extended it to June 1st. So we'd love to see more applications for that program. And there will be a small stipend if you're selected. So thank you.
Thank you so much, Rochelle.
Oh,
sorry.
One thing, which is that this has been recorded, and so it will be available on the community of practice once we get it all uploaded.
So we just wanted to close really on behalf of our team by saying thank you so much for joining us, and also really just expressing that you're in our thoughts. You know, this is a really difficult and uncertain time, and I think we feel really grateful to be part of this community and thinking about patients, families, our colleagues, and others, and everyone that we serve. And so we're thinking about you. We're here if you ever need anything, and we deeply appreciate you taking the time to be with us today. So thank you all very much, and we'll connect soon. Bye-bye.